and there's a massive difference in leg length. It's a 21 millimeter difference in leg length. Now, this is someone that was told by their medical doctor not to worry about it, or at least not to act on this. Hey everyone, Dr. Todd from Gonstead Spine and Wellness. In this video, we're gonna talk about short legs, leg length inequality. Everything you wanted to know. This is gonna be for the public and for chiropractors because this is a very common topic that is misunderstood. Also physical therapists, if you're watching this too, check this out. I'm gonna give you some insight that maybe you didn't know, or it will at least show you the importance of taking x-ray. You know, we're big fans of taking x-ray. There's a link up above on why we take x-ray, why that's so necessary, so check that out. Before we get started, make sure you subscribe to our channel, like, comment below. Commenting helps a ton, so please take a second, just put a comment below, put anything, put great job, put a question, put I have a short leg, I walk in circles, whatever you wanna put below. Comments are great, so please go ahead and comment below. And we serve two audiences. One is the public. We help the public understand about topics that relate back to natural health and healing so that we can empower you with knowledge so you can take control of your health and you can live a long, healthy, happy life. How cool is that? Also, for people that want to come into our clinic, there's the info below. We take care of, we teach chiropractors. We teach functional movement and corrective exercise, how to put this into your chiropractic practice so you can address all these things and get the best results possible. That's called Move Now University. There's a link down below as well. Let's get started with this one. We're gonna discuss leg length inequality. And with that, we're gonna switch over to a computer screen. We're gonna go into my office. So let's get going. All right, we're here in my office. So I have screens, I have some x-rays pulled up. I'm gonna take you through a couple different scenarios. Some of these are gonna be before and after addressing the leg length inequality. First off, before we even get into this, let me just explain that very oftentimes we have patients that come in, they've seen a physical therapist or chiropractor or personal trainer, and they're told that they have a short leg, okay? And they're even given a lift or something to put inside of their shoe to correct said short leg. Now, while this is something that we do identify visually on posture, we have to confirm this on x-ray. It's very important to confirm this on x-ray. We do not ever put a lift inside of someone's shoe without seeing what's going on structurally, making sure that there isn't any sort of contraindication to putting a lift inside the shoe. Because you can make something worse with a lift. You can put a lift in even though the leg is short, but because of what the spine is doing, it might make the person worse. These are things that as a trained chiropractor and understanding spinal biomechanics and postural patterns, we have to look at this and put our expertise into it to know if it's appropriate to put a lift inside the shoe. If someone has a short leg and it's causing the pelvis to drop, how is that affecting the spine? There's a predictable way that we expect this to affect the spine. And in doing so, if we put a lift inside the shoe, will it correct that problem in the spine? Now, this one right here, this is a pretty minor compensation in the spine, but this patient has a 14 millimeter difference in leg length. So you'll see right here how we measure it. We put a line across the top of the femur heads, and then we measure how much of a difference there is from level to the horizon. Okay, so level to the horizon is where the top of the femur head should be. We go up to the sacral base, and keep in mind this x-ray, we're looking at the patient as if we're standing behind them. So I'm gonna orientate this plastic model the same way. So we do a line across the top of the femur heads, and then we look at the top of the sacrum, and we see if the sacrum is tipped one way or the other. And then we wanna see how that affects the spine. Is the spine curving like this one is to the side of the short leg? That is a common postural compensation pattern. So if you look at me, for example, and let's pretend I have a short leg. This is on the right side. I'm gonna turn around so that you're looking at me from the back, you're looking at the spine from the back. If I bend my leg, I'm gonna shift like this. That's a common pattern that you'll see. And also, about 80% of the time, they've showed in research studies that there's also a predictable way that the pelvis twists on the short leg side. So most of the time, when you have a short leg, the pelvis rotates forward on the short leg side. There's still a percentage where it doesn't do that, it does the opposite. And that might give us as the practitioner some idea that maybe the body isn't compensating the way that we would expect it to compensate. Maybe this is more than just a short leg, maybe there's trauma involved, there's really joint restriction, fixation, all kinds of other components that are layered on top of the short leg. That's the way that we look at this, but this is one scenario of a short leg. This patient got a lift. We put a 12 millimeter lift inside the right shoe to help level this out. I don't have a post x-ray on this one, but I'll pull up a couple more. Okay, this one is actually a patient of ours that lifts very heavy weight. This is a bodybuilder patient of ours. had a fracture in the right femur. You can see some screws in here, so at a young age. And whether this contributed to or didn't, it probably did contribute to it, but I don't know for sure because I've seen it go both ways. I've seen traumas to the leg and then that leg ends up being the longer one. I've seen traumas to the leg and it's the shorter one. More commonly, it's the shorter one. What's happened here is this difference. This is almost 19 millimeters. Now keep in mind, we measure in millimeters. It's about 25.5 millimeters is 1 inch. So this is pretty close to 3/4 of an inch. That's significant. Look how much that's dropping the pelvis on this side, and look how significant of a curve there is. It's compensating the way that you would expect it to compensate. It's convex, so it's shaped this way on the side of the short leg. And now this is someone who's squatting, who's deadlifting, who's loading his spine, and he's having severe low back pain. On the side view here, you'll see his 5th lumbar disc is much thinner than it should be because this guy is not all that old, all right? So he's in his early 30s. You shouldn't have that thin of a disc in the low back at that age. I mean, that's just not ideal. You want a thicker, healthier disc. On this one, we actually put in a lift and we did a follow-up x-ray, and this says 18 millimeter heel lift. So we put a lift in. Now you can see more of the hardware in that femur right here. And we got this down to a 2 millimeter difference. And comparatively, there's much less bend and twist in the spine. I'll make sure we throw these up on the screen side by side so you can see them. On to this one. This is another patient of ours that's a little bit older, female. Very significant curve. You'd call this a scoliosis because it's such a sharp bend. And there's a massive difference in leg length. It's a 21 millimeter difference in leg length. Very significant. Now, this is someone that was told by their medical doctor not to worry about it, or at least not to act on this. We had given them feedback that they should act on it. Fortunately, they listened to our expertise, they acted on it, and this is too big of a leg length difference to put a little lift inside the shoe. I'll put a picture up on the screen of what the lifts look like. They're little foam wedges that go inside the shoe. You really can't put more than 12 millimeters, half an inch, inside of a shoe before the heel starts to pop out of the heel cup. So essentially the shoe just allows the heel to pop out, you rub on the heel, and it's a mess. So 12 millimeters is the max that you would do inside the shoe. When it exceeds that, and when that person needs to build it up bigger, they need to go to an actual shoemaker and have them disassemble the shoe and put that inside the shoe. And I'll put a picture up on the screen of what modified shoes look like. They do a really great job. I know from a patient standpoint, the worst thing in the world, you think, oh my gosh, I have to wear these crazy looking shoes. Fortunately, you don't have to do that. They do a great job matching the color of the material. You're the only one that's gonna know that you have a modified shoe, but it will make a tremendous difference in your life because you wanna handle this. Not only does this cause early degeneration of the spine, but this can cause pain. It will cause tension to the spinal cord, and this can actually get worse. And a thing that we're really trying to prevent on these is something called a lateral listhesis. And that's where the spine starts to side slip. So you have a really harsh bend in here, and then a vertebra, it's usually L3, sometimes L2, sometimes L4, but usually L3 starts to side slip. So if I go this way, and this model might not even help me do it, but it starts to, yeah, there we go, starts to shear out to the side like so. That's a really bad situation to be in. We can see right here at L2, you're starting to see some side slip. The lateral border of L2 is further this way compared to L3. That's why we want to correct postural distortions like this. That's why as chiropractors, we care about this. So speaking to other chiropractors to say, you should just adjust. You shouldn't focus on any of this stuff. That's what physical therapists should do. That's what someone else should do. You're rolling the dice and really just wishful thinking that someone else is going to handle this in a way that is consistent how a chiropractor should handle it when we have a great grasp at spinal biomechanics, when we have the x-ray, and when we have the know-how as far as how to fix this. Now, something else too that I'll mention, all of the postural corrective science, it's done best by a group called Chiropractic Biophysics. It's one of the 3 techniques we do in our clinic. I'll put a little link up above talking about how a chiropractor spoke to us one time and told us we should take our mural of Gonstead off of the wall because we're confusing the public, because we're not doing pure Gonstead. We're not. We do Gonstead for the segmental adjusting. We do chiropractic biophysics for the posture correction. Go to a CBP seminar. If you're a chiropractor and you want to learn it, they do an amazing job teaching this. And then third, we look at functional movement patterns. We take a patient like this, we take them through a movement assessment. We then look at how they did in the movement assessment, and we prescribe corrective exercises based on that. And all 3 of those things, the segment, the posture, and the movement, they all work together to get the best transformative results for our patient. So right here, what we did is we sent this patient out to get a lift actually built into the shoe. And then this is the follow-up, all right? And we'll make sure that we put these side by side so you can see them on the screen as well. But what happened is it reduced this curve. It brought the pelvis up quite a bit. You can see there's still a 3 millimeter difference. It says left heel lift of 15 millimeters. So this is less than a full correction, but on a comparative x-ray, we wanted to look and see how that turned out. Now, granted, this is after a patient went through a few months of corrective exercise, of traction, of multiple things to get the spine malleable enough to even accept this kind of change. If you just stuck a lift in there and went and took an x-ray right away, which we've done that plenty of times, a lot of times what will happen is this is so rigid, it doesn't just flatten out and straighten out to this extent. So it takes some work from the patient, from our team, to help get this thing malleable, get the muscles more symmetrical, to get the joints that are fixated, unlocked and moving properly to allow a correction like this to take hold. Next one, this is going now to a pediatric case. This is a patient, I believe he was 4 or 5 years old when he first came in. I take care of this whole family, amazing family. They noticed that their little boy, his shoulders were unlevel. So if you ever notice this in your kids or your patients where the shoulders are unlevel, that should make you think this is a small child, their shoulders are unlevel. Is it a problem up here with a head posture, or is it a rib cage shift being driven by a leg length inequality, by a short leg? We visually looked at him and we could see that his left leg looked dropped. We went and took an x-ray, and sure enough, it's not a huge measurable difference. It's about 3 millimeters, but look what we found. So this is a problem where his femur head right here is not developing properly. This is avascular necrosis to this area. That means he had a lack of blood supply. The bone wasn't developing properly. This was a referral out to a pediatric orthopedist so they could look at this and they could give their feedback. Fortunately, they said no action needs to be taken. Their feedback is wait and see. Our feedback is wait and see, but in the meantime, let's do things mechanically to shift this thoracic spine, the torso, off of that short leg so that it has an opportunity to catch up and we can help correct and center this posture in the meantime. Now, there's a couple of bone growth laws I'm going to cover here real quick. This is great information for the public, also for chiropractors, great speaking points to understand and also educate your patients on, and the importance of kids getting x-rays at a young age. We recommend x-raying kids at 3 years old unless there's trauma prior to that so that we can start to investigate these things. Because as a parent, do you feel like it's your responsibility to know how your child's spine is developing? I mean, who else is going to look out for this? I can tell you our little boy, when he was 3, we took him in, time for x-rays. He had a slight short leg too. We've put a lift inside of all of his shoes to help center that so his spine continues to develop in the most advantageous position possible. We'll actually be taking a post x-ray of him pretty soon to see how that bone development changed. Now, here's how that's possible. In adults, there is a bone growth law called Wolff's Law. Wolff's Law says that bone remodels due to stress. So if you have more load and more stress, this is a short left leg. So if you have more load and more stress on this left side, Wolff's Law says that left side, you're going to have bony growth that compensates. You could have increased density and possible bone spurs and all this stuff happening on that increased weighted side. Well, in kids, there's an opposite bone growth law called Hütter-Volkmann's law of immature bone. What that is a law that says when you have more stress on bone, it will retard the growth. It will slow the growth. It will not grow as quickly. So now you can see how much his rib cage, his torso is shifted on the short leg side. This is 2/3 of someone's body mass, this upper body torso. So 2/3 of the body mass is shifted over, loading down on this leg that we already know is growing slow. Hütter-Volkmann's law says that's going to cause that to grow even slower. And chances are it's not going to catch up. It's not going to even out on its own. So we need to do something to intervene to help with this. So what do? We put a lift inside the shoe. We teach some corrective exercises over. We even do some body weighting where we have his mom put some water bottles in a backpack on the left side over that left shoulder, which will then force him to either fail into it if it's too heavy or compensate over and shift the other direction. And you start to work the brain. So the brain centering mechanism looks at this and says, ooh, it's not normal being over here. I want to be over here. You lift up the leg. So you have a mechanical intervention. And then you have corrective exercises. So you have that motor control input to the brain as well. So there's many components that we use to get someone shifted over. And of course, it goes without saying, we want to adjust the specific segments that are restricted, that are fixated, that are not moving. That's what we do with specific chiropractic. Now, his follow-up x-ray, granted this is a couple years later, so he's a whole different spine at this point. This is where there's a lift inside the shoe, and we actually overcompensated purposely. There's a 6 millimeter lift on the left. We know that we're bringing this one up higher, and we're actually making this one slightly lower. But look, his spine still wants to slightly bend to the left, so it helps it tremendously. He overcompensates up here. This is something we're doing to try to unload this so this can continue to grow more normally. And he got checked out by the orthopedist and they said this is actually doing quite well. And it looks like it's moving in the right direction. Part of it is because we know that the body just heals itself. And two is we added some variables in here to help offload that leg and give it some extra help. That's our job as a corrective care chiropractor. Couple more x-rays and then we'll round this out. All right, this one is a gentleman that came in that had a massive difference in leg length. He's been to multiple chiropractors, physical therapists. They said maybe you have a leg length difference. You don't need to put anything inside of your shoe. It's a functional short leg, which let me explain that real quick. We'll end on this note. This is another heavy concept. So pelvis right here, the pelvis should be nice and level. A lot of chiropractors have been taught, I was taught this as well, and then I learned it just isn't the case, is that there's a ton of movement in the sacroiliac joint, the joint between the pelvis and the tailbone. And all that movement, if the pelvis, if the SI joint misaligns, it could crank this leg up and make a short leg on that side, or it can push that leg down and make it longer on that side. Well, we found out over the years that there's actually a lot less movement in that sacroiliac joint than we originally thought. There is still movement, especially when someone has a sprain. When someone injures the joint, it can shift, it can misalign. So it's very important, and small amounts of misalignment are very important, so don't get me wrong. It just doesn't move as much as we were taught or we thought. So now when this misaligns, even if it does in a massive level, this can draw the leg up on the side and make it a little bit shorter. So this is called a posterior inferior or a PI ilium. There's other dimensions that can move too, but let's not go down that rabbit hole quite yet. So when it goes like this, it can draw that leg up and it can shorten the leg on that side. And a lot of physical therapists and chiropractors alike say, oh, it's a functional short leg. Physical therapists say it's because of muscle. Chiropractors say it's because the joint needs to be adjusted. When the reality is a lot of these patients have an anatomical short leg, meaning their femur is shorter, so their leg bone up top is shorter, or their tibia down low is shorter, or in some cases, and it's not going to affect it to this magnitude, the foot is extremely pronated, flattened in, and that can drop the entire leg on that side a couple of millimeters. Now in this case, this guy was told don't do anything about it. Massive curve, very hard bend, extreme short leg, 19 millimeters. He went and had his shoes built up. His life has changed dramatically. He only saw us a couple visits before he had to travel out of town for work. He got his shoe built up, went out of town for several months, just came back in a few months ago and said, oh yeah, I have all my shoes modified. And it was the world of difference. Now, of course, we're adjusting him. We taught him some exercises. He has some home care stuff that he's doing as well. He's got an increased curve up here. The head is sticking forward compared to the rest of the body. So this is not a one and done, it fixes everything. Oh, and his head's translated off to the side as well. But this is just showing you that you want to make sure that you're getting really good advice from someone. And if you're a practitioner watching this, change your ways. If you're telling patients, don't worry about it, it's not a big deal, make sure that's because you're an expert in the subject and it's not just because you don't know any better. I used to tell patients this back in the day too, before I knew, because that's how I was taught, that, oh, well, let's not worry about it. If it's affecting how you hold your adjustments, then it's a problem. But if not, don't worry about it. The problem is this will cause the spine to degenerate and break down prematurely. So we want to address this. The spine is healthiest when it's straight up and down, and it's healthiest when there's a certain alignment on the side view. We did a whole other video about posture, so you can check that one out. We'll link that up above so you can take a look. And there is a normal posture, just like there's a normal blood pressure and there's all these normal ranges of things in the human body. There's a normal posture. There's a lot of science and studies to back this up. So we have other x-rays we could show, but I think you got the point. This video is long enough. We're gonna cut it there. Comment below, let us know what you think. Throw out some questions if you have any questions. Dr. Todd signing out from Gonstead Spine and Wellness. When it comes to the health of you and your family, results matter most.